measured by optical coherence. So there's focal weakening in your corneal stroma in epileptic eyes. So what does that mean? So even if you do LASIK, PRK, or whether you do LASIK or SMILE, because the anterior cornea is really affected in keratoconic corneas, then it doesn't matter. No, they say that PRK might be a safer option because you preserve most of the cornea. No? So that is one interesting study, but we'll see what comes out of it. So what are the risk factors for ectasia? In 2018, in 10 eyes of 7 patients, the most common risk factors seen were a thin cornea, no? So abnormal topography or tomography with anterior map irregularities or posterior elevation more than 15 microns, a low residual stromal bed, no? And a percentage of tissue affected more than or equal to 40%. No? So these were the most common risk factors that were seen in patients with ectasia. Another risk factor might be the use of a microkeratome, no? Because if you use a microkeratome, even if you target 110 microns, the flap thickness can vary between 86 to 160 microns. And also because of a meniscus-shaped flap, the peripheral flap thickness can go up to 167 microns. Also, because you create it over a wet cornea, you might the cornea might be a little bit more swollen or thicker, so you get a thicker flap, no? Compared to a femtosecond flap wherein the stroma becomes dehydrated. So because of refractive tissue removal, there is biomechanical weakening of the cornea, no? So post-operative mechanical trauma or stress like constant eye rubbing can cause mechanical, biochemical, and biomechanical changes in the cornea, no? That includes keratocyte apoptosis, wherein mechanical and also mechanical compressive forces produce a shearing effect, no? Again, there might be subclinical atopy. There might be subclinical atopy in our patients, no, which we can never elicit, no. So because the incidence of keratoconus in the population is around 0.054%, no. In 2018, a study saw that 4,500 out of 30,000 eyes had the potential risk of ectasia. But out of the 4,500, only 10% were pushed to ectasia. So that's a silver lining for us, no? So even if there are some signs, no, sometimes really we cannot predict who will get ectasia or not, no, and the incidence is very low if we counsel our patients, no, regarding eye rubbing. So I'm presenting 3 cases from our center for the past few years, no. So patient 1 is a 22-year-old male, no, and 2 years and 2 months post-op, he presented with an uncorrected distance vision of 20/50 and on the right eye and 20/30 on the left eye. Oculizer or pentacam was done, and you see a steepening in the center for the right eye and also on the left eye, no? So you can see it better in the topography, no? So there's steepening here and also here with a cylinder of almost 4 on the right and 2.5 on the left, no? If you can see the pre-op screening, they mostly normal, no? Cornea was thick, normal. Only an oblique astigmatism was seen on the right with normal posterior elevation and normal Kleist-Meida and Smollett and Kleist indices. Same with the left eye. You can see the Bellin-Ambrosio map, no? Normal, except for some borderline findings here. So for our second page, please. 22-year-old patient. Story like that. Alarm? Rainfall. Okay. Sanay tayo bahain, di ba? So, 3 years post-op, the uncorrected vision was 2025, It's 2025, but when you do the topography, it's like this, no? So, how do you have an inkling when to, normally you should really ask for the tests every year normally, no? But syempre, it's also expensive and you don't want your patients to shell out money. So sometimes when you look at the um, AR, no, you'll see even if they're 2025, you'll see there's high astigmatism and a little bit of hyperopia, no? So that's where you start to think, no, is there anything else happening in the cornea? So you ask for the topography and tomography, and you see there's the abnormality, no? So pre-op also fairly normal, no? So for uh, corneal thickness is around 517, no? Here still normal, but you can see a very slight elevation inferiorly. For the left eye, more also normal pre-op values. Also with our Bellin-Ambrosio report. So the surgeon opted to wait, no, for a few years before doing cross-linking, no. So or I don't know if the patient was lost to follow up, and then when she came back, the vision was 2050, no. So a cross-linking was, and the steepening was more prominent, no. So cross-linking was done, and yeah. So cross-linking was done, and after, sorry, let's go back. So after cross-linking, vision became 2050 improved to 2025 with a manifest refraction of -175 with 200 cylinder. So the third patient presented 5 years and 3 months post-op with a VA of 2080 on the left eye, no? So you can see in the topo, no, so very prominent inferior steepening of the left eye. So pre-op findings also fairly normal, no, for the right eye and the left eye of the patient, no. So cross-linking was also performed, no, on this patient, and VA post cross-linking was 2030 improved to 2025 with a manifest refraction of 0.75 with -275 cylinder, no. So you can see the map here. So what are the indices or score systems that we can use to screen for possible ectasia in our patients? So the most common, most popular is the ectasia risk score system of Randleman in 2008. So our parameters include the topography, the residual stromal bed, the age of the patient, the corneal thickness pre-op, and the manifest refraction. So here you have low risk, moderate, and high risk. Other is the percentage of tissue altered, no? So, sorry. So you have the flap thickness and the ablation depth over divided by the corneal thickness. So they say that patients are high risk if the flap thickness and the ablation depth are 40% or higher. So as they say, the entire 40% of the corneal stroma has significantly greater tensile strength, no? So removing this may induce corneal weakening in increasing proportion as the threshold of 40% is reached and crossed. Another index is the NICE, no? With the parameters of the steepest K, the posterior elevation, the central pachymetry, and the inferior superior asymmetry, no? So These are the this is the scoring system for that. For the pentacam, we have our parameters, no? We have our topometric indices, the index of height decentration, the inferior minus superior value, and the KISA index, no? For the Bellin-Ambrosio enhanced ectasia display, we have the BAD-D, no? And then for Ambrosio's thickness, we have the artmax. And the newest is the AI-based pentacam random forest index, no? So when you look at your pentacam results, no, this is where you'll see those parameters, no. So we have the IHD here, we have the artmax here, we have the Bellin-Ambrosio display here, no. And then for if your center has an Oculus Corvis machine, no, so you can look at the biomechanical strength of the cornea. We have our IS value here and the forest index, no. So the Corvis is still not gold standard, no, for or testing for corneal thickness, corneal strength, because of they still don't have normative data, no? So sometimes they say if the patient is younger, sometimes it's more what do you call softer, no, the cornea. So they still don't have normal data, but it's a good addition to the armamentarium, no? Especially if you have doubts, if you're screening and you're looking at your topo and your tomography and you have doubts, then you can have the Corvis done, so to augment your pre-op data. So what are the other risk factors that were seen in some of our studies was the age of less than 25, no? Use of microkeratome flaps, no? I just highlighted those more than 50%, no? The other, the ERSS more than 3 points, and the PRFI index, no? The others are a thin pachymetry, so anything less than 550 microns, sometimes you have to be worried, no? BAD-D of more than 1.6, an artmax less than 340, PTA index of more than 40, NICE of more than 8. But in 8% of patients, again, there are no identifiable risk factors, no? So these are all in hindsight, no? So because they're doing the studies after they have the ectasia patients already, no? Napauwi na yata tayo. Okay. So what are the risk factors for our 3 patients, no? So patient 1 was a 22-year-old male, patient 2 is a 22-year-old female, and the patient 3 was 22 male. So lahat sila 22. I don't know why, no? So refraction not so high, no? Minus 250 with 375, 6 and minus 5. Pachymetry, makapal, diba? 559, 557. This one, 518, 518, no? Residual stromal bed was still thick, 350, 350, 325, and 312, no? So, what was taught to us was 250, diba? No? But now we're a little bit more conservative. I usually target 300, no? 290, pwede. But dati, I still go to 250 ngayon, hindi na. Mas nakakatakot na. So, PTA was less than 40%. ERSS 222 for all. This one, borderline at 2.15 to 17, no? The artmax was 328 here, 322 here. But the most common factor for everybody, for all of them, was aerobic. So you actually should tell your patients, lahat sila, after refractive, even before refractive surgery, no, but especially after refractive surgery, no aerobic, okay? Okay, meron yata ang aerobber dito sa arab ko. Ikaw makapalisik ka.
Smile na yan.
Smile ka na pala. Too late. Let's see what happens. Okay. So, Some surgeons perform cross-linking, no, during refractive surgery, no. Um, Systematic review of databases with 2,800 eyes saw that post-operative corneal thickness was significantly reduced in the cross-linking group, but no cross-linking group demonstrated a better safety and efficacy profile. No? Overall, corrected distance vision was significantly reduced, but uncorrected distance vision and manifest refraction were comparable among both groups. The most common complication of cross-linking, as we know, is transient corneal haze. No, so, um, but there was no ectasia seen within the follow-up period. So, for me, some surgeons do cross-linking. No, just maybe for peace of mind and just to decrease the incidence of ectasia. But if you do a proper pre-op screening and maybe call this counsel your patient well, you might not need cross-linking. No? So if you're very you really have doubts, then don't proceed. No, you have other options naman eh. You can do ICL, no, so that's a good thing because before we didn't have phakic lenses that were good. No, so that's another option. So what is the treatment of ectasia when you have patients presenting to you? No, so the preferred procedure is still corneal collagen cross-linking as we do in keratoconus, no? So we have different protocols, no? Uh, Also, some doctors perform PRK together with the cross-linking, no? So to um, correct the refraction, but sometimes an unpredictable flattening effect may cause a hyperopic shift, no? We can also insert intracorneal ring segments or um, also use phakic intraocular lenses, no? Other options for visual correction would be contact lenses, and the worst case scenario, we do lamellar or full thickness keratoplasty. So for corneal collagen cross-linking, as you know, we use riboflavin and UVA to create bonds between collagen and the proteoglycan molecules. No, there's a new study with a modified Cretan protocol, no, in 2024, where they do transepithelial PTK with accelerated cross-linking. No, so you do a 50 micron, 8.5 millimeter ablation, expose the cornea to hypotonic riboflavin every 2 minutes for 30 minutes and UV radiation of 10 minutes at 9 milliwatts per centimeter square with riboflavin every 2 minutes. So they noted a decrease in both K1 and K2 of patients. Anterior and posterior elevation improved at 24 months. And corneal thickness was noted to be decreased at 6 months, then started to recover at 12 months. And so in summary, for corneal ectasia, really prevention is better than cure. No? So as with our keratoconus patients, no, we always counsel them really no eye rubbing. No. Uh, you really have to ask them for the history of allergies, no? Because a lot of patients now have allergies, diba? So you give them lubricants or mast cell stabilizers and antihistamines, no? So make it a habit for them, no? Although we do thorough preoperative screening, sometimes really you cannot control your patients from rubbing their eyes, no? You have to do a regular follow-up. So usually every year, no? But if there are problems, pwedeng every 6 months, no? If ever, yeah, you encounter ectasia, then you can do cross-linking and try to improve the patient's quality of vision. Okay. Thank you for your attention.
Okay, thank you so much, ma'am, for your lecture. It's very interesting and it's very significant now, especially since we have what around 2 million laser vision correction procedures done worldwide. I'd like to acknowledge pala the presence of Dr. Francia and the residents from WVMC because I mean this is also a very important, like significant lecture for them because there's also a LASIK center in Iloilo. So for sure, some of them might encounter patients who are interested in refractive surgery or some patients who might have risk factors for developing corneal ectasia or who already have this. In your uh private practice, ma'am, like which parameter do you follow more in terms of screening out or fishing out patients who might be at risk for developing ectasia?
So yung the pentacam, no, with the Bellin
That's fine.
Ambrosio. So that's the most important. Usually because 'di ba it's color coded naman eh. So
Yes.
isang tingin pa lang you see yellow and
Pag
there's
yellow or
red.
red, yes po.
Ayun and for me the topography talaga is very very important, no. It's really because you see it with the pentacam kasi 'di ba it's difficult to look at the map. No, it's very difficult
Yes.
to decipher the map. So kami, I don't know if anybody uses the CLICE and the MAIDA indices
I haven't
pa.
tried. I
Oo
haven't
nga eh.
tried
For
po.
me, very, very ano siya, parang it's a good tool, no? Kasi kung if you just have the pentacam, kung minsan you miss something, no? At least you have something to back up your what you see, no? So for me, if I have doubts, no, sometimes if it's overt, you know it na, di ba? If it's borderline, sometimes you treat the dry eye first. Sometimes it's just dry eye.
Yung
No? So,
topography will change.
'di ba? Yung topography
Mm.
sometimes may inferior steepening and then you give lubricants and after 2 weeks it's gone. No? So ano lang siya, it's because of dry eye. So if we have doubts, we have the patient do Corvis, no? Do Corvis test, no? But sometimes kasi lahat ng kino-Corvis parang lumalabas,
So,
don't do
so
surgery.
yes. Ma'am, saan may Corbis pala? May
Sa
Corbis ba sa
medical city,
Philippines?
sa medical
Ah, okay. Okay, nice to
meron.
know.
And they have a reading na rin. Kaso lang yun nga. So, um, I think it's more ano rin, what do you call this? The more as you see, the more, di ba? The more that you
Yes.
have the, ano na, the, what do you call this? Yung, you develop your clinical eye. And yun nga, if there's any doubt, the ICL is
Don't know.
there.
Yun na, at
Don't
least
do it.
there's the ICL.
Yeah, but di ba kung minsan kasi ang na-narrow ng anterior chamber ng patients natin eh. So wala
Yes
rin.
po.
But I always tell my patients, very easy to do refractive surgery, but if something goes wrong, it's very difficult um to
It's
treat or
catastrophic. Yes.
yes, oo. So meron yung mga 'di ba mapilit ganyan kahit hindi na pwede. Pero you have to tell them, you have to be strict and you have to be really tell them this is for you. This is not, di ba? This is more for the patient's well-being.
No po.
I think.
Ay, Dr. Mere has a question po.
Yes, Doctora, thank you for your very good lecture. I'm just wondering, when you monitor patients post-op, how do you actually distinguish post-op ectasia from regression or dry eyes with topographic noise?
So, one is you look at the refraction, no? So if it's correctable to 2020, like most probably it's regression, no? So kunyari may -1, -150, and the pattern, if you do the topography map, you can see naman eh if there's a focal steepening. For
Yes.
us, usually, di ba? For us, usually talaga may ang tinitingnan ko really is the AR, no? The AR is weird,
Mm-mm.
diba? See an AR that's so weird.
Yeah.
And then do the
Yes.
refraction, parang ang baba lang nung refraction. And then yun yung parang sign mo. And then you do topography initially. I really like the topography kasi kitang-kita mo yung map eh. Kitang-kita mo there's something wrong. So, yun. And then,
Yes.
when you tomo, then it's, yun, you see the ectasia.
Thank you. Thank you, Doctora.
Okay.
Any
Mike,
other questions?
Mike has a question.
Don't worry about patient that you're considering to be like your
Ah,
basic. Is that
yes.
an independent risk factor for ectasia, or is it primarily related lang to the baseline for
I think
fitness?
baseline pa rin. But syempre, when you repeat you enhance, you thin out the cornea more, no? But for us, parang wala pa akong na-encounter na ectasia after enhancement, if I remember correctly. Most of them talaga primary, no? So, we do a lot of enhancements, no? So, yun lang, sometimes when you do the tomography, hindi na rin siya normal, di ba? So, you really have to take a look at the posterior. Yung posterior naman ang titignan mo for that. And also thickness. Kasi baka ma-enhance ka. Sa karab
Smile
mo.
naman siya, ma'am eh. Smile naman siya.
Smile naman siya.
Smile yung
Buksan
kay
natin.
Mike eh.
Oo nga, buksan natin. I-circle software natin. Any other
Um, ma'am,
Go.
pag for cross-linking for post-LASIK ectasia, like, what do you do? Transepithelial or do you do it under the flap po? Kasi literature more than transepithelial.
Transepithelial. Transepithelial pa. Ay, parang feeling ko, don't disturb the flap na, di ba?
Yan nga eh. Tapos, yung corneal thickness pa, I mean, it might go into the endothelium also. So,
Yeah.
yun lang yung
Oh,
concept.
mas problema pa, di ba?
Yeah.
Yeah. Because sometimes, some patient, for us, when we enhance kasi, we lift the flap, di ba? Tapos,
Mm.
what's in UCLA, after 6 months, transepithelial na sila. PRK na sila. They don't
Mm,
really lift the flap. I don't know why. Maybe they're scared
even
of
for enhancement. Okay.
maybe they're
Oh.
scared of ingrowth or yeah. Pero 'di ba, mas madali yung ano. I really don't like doing PRK because of the haze,
No.
'di ba?
And it's not as predictable if you do PRK over yung sa LASIK flap sometimes.
Yes, so
So,
yeah. If you open it super fast lang.
oh,
Ingrowth sobrang rare naman eh, 'di ba?
yes,
Hindi naman
ma'am.
ganun kako.
Yung mahirap lang din kasi ma'am, pag kunyari enhancement, and then like, I've seen some patients, I've handled some patients na LASIK with cross-linking yung initial nila. It's so
Hmm.
sticky to open the flap also, sometimes delicate.
Oo, oo. Wala kasi kami
Longer
masyadong
yung OR time.
tama. Tama. Baka pag ganun ano mo na, PRK mo na lang.
PRK.
Hmm.
Scary din. Ano pa? Does anyone else have any questions about this topic?
Rich has a question.
Is there a particular time where the risk of ectasia would go down after refractive procedures, or is it more of a
Age. The age. So, mga siguro 30s, 40s. Compared to the 20s, tignan mo, all the patients are 22. Di ba? So, as you age, your cornea becomes stiffer. No? So, less chance. Unless they rub. So, di ba your keratoconus patients, pag 30s na, stable na sila. Unless they really rub. Kasi yun, wala kang magagawa. Okay. No more questions. Dami nakasalamin.
None na din, ma'am, sa online.
Nakasalamin dito.
My question, Dr. Minister,
Yes.
have you ever had to do a recross even after the first cross? It can happen.
Haven't.
So if you need another cross-linking, then you might need
Kasi,
other procedures.
oo. I've never done a recross linking.
A cross-linking.
Hi, Dr.
Ayan.
Neil.
Ma'am, si Neil has a question.
Hi, Doctora. It's Neil. Um, a wonderful lecture. I just have a question about because I heard in the discussion in a separate lecture that in cross-linking patients eventually pag nag-phaco sila don't use multifocals because of the higher order aberrations. Is that true?
Hmm, haven't heard of that. Maybe because di na siya regular.
Yun nga.
Maybe John has
It's a
more
lecture that I've listened to parang don't use the multifocals in these patients. Monofocal
or
toric lang.
maybe because initially they're really keratoconic patients na.
So not all cross-linking, just the keratoconic ones. Kasi sabi mo na
Oo.
some surgeons will cross-link as a principal.
Yeah.
But kasi when you do cross-linking with refractive surgery, it's very fast lang eh.
Yeah.
Yes,
Yung
ma'am.
basic,
1 minute. 1 minute.
yeah. So, 1 minute lang. So, I don't think it will be a factor. Maybe it's more of for the keratoconic corneas talaga.
Although maybe I might avoid din Neil yung mga refractive na multifocal lens. Baka mas diffractive lang kasi yung tendency na mas maging aberrated. Usually hyperopic sila, ma'am. Yung mga post cross-linking
Yeah.
na with laser. Mas hyperopic
Mm.
shift sila po.
Hmm. I'm asking this kasi in particular, napapansin ko po is even in the government hospitals na, there seems to be a move towards EDOF and mga toric lenses because nga PhilHealth is allowing them na. So I'm wondering if
Yeah.
there's certain subsets of patients talaga we should just, stick with the tried and true monofocals.
Yeah, those might be
I would.
yes. But for me, my post-LASIK patients, if not significant na may aberrations, I still use EDOFs. And it
Thank
works,
you.
but it's not wow. But still works, no? Kasi syempre, you have to balance and because initially nga they had refractive surgery. So sanay silang hindi nagsasalamin. Tapos
Yeah.
after surgery, magsasalamin. So parang hindi sila happy as much
And
as
the worst
possible.
kasi diba refractive surgery patients sila, so they're gonna be a little bit more demanding than normal pa. So
There's
after
higher
cataract surgery,
expectations.
Pero yun nga, you have to be firm. Kung hindi talaga pwede, tell them it's for your own good. Diba? Kasi ikaw rin sisisihin pag hindi sila happy.
thank you so much, Doctora.
Thank you.
Okay. I think, does anyone else have any question? Oh, I think that's it, ma'am.
Okay, thank you.
Ay, yeah. I think okay na, ma'am.
I think thank you so much, Doc Ellen and Joan for today's conference. Thank you as well to the attendance of the Western Visayas Medical Center. See you all next week. Yeah. Thank you. Thank you so much. Bye-bye.